So hello, it's just turned 12 o'clock, so I thought I would just start by saying hello to everyone who's joining us today. We've got about 5 minutes to just make sure everyone who's joining the webinar is connected. So just a reminder that this is a webinar, so all your microphones will be muted throughout the presentations, and today's webinar is being recorded. So the recording will be available on the RCSLT YouTube channel afterwards, and our presenters today have agreed that they're happy to share the slides. So the slides will be available in a Google Dropbox, and access to both the YouTube channel and the Dropbox. So I've just realised my video wasn't on. So access to both the YouTube channel and the Dropbox will be available via links on the RCSLT website. And I will try to get that website link maybe put into the chat box for everyone to see. So just to start with, my name's Catherine, and I'm chairing today's presentations. And my colleague Helen Cameron is also behind the scenes sorting out the slide show for us. We are both responsible for coordinating the practice-based research seminar series, and as ever we're really grateful to our presenters today. We've got a fabulous list of presenters. So Lucy Rodgers will start us off talking about co-occurring speech and language needs with people who have a DLD profile, developmental language disorder profile. And then at 12:22 we'll move on to Anna Westaway's presentation, which is about parents' experiences of how healthcare professionals communicate with people who've got autism, autistic spectrum disorder. And then at 12:40, Jenn Warwick's going to talk to us about the development of a sociocognitive communication battery. We've just got another few minutes. I'm not going to talk for the next 3 minutes, but just a reminder that if you've got any questions during the seminar, then please pop them into the chat box, and I'll gather the questions, and hopefully each panelist, each presenter will have a few minutes at the end of their talk to be able to address those. We'll also try and capture the questions and send them on to the panelists, but we've asked them to share their email addresses with you, so please feel free to contact them directly if we don't get around to addressing your particular question during this seminar. If you'd like to tweet about the seminar, any learning or experiences that you want to share with the wider Twitter sphere, then please tag us with the hashtag PBR seminars so that we can capture some of your thoughts and experiences. And again, if you've got any feedback, please contact Helen or myself, and we'll try to address your feedback, and we're seeking to sort of just grow and develop and these series. And equally, if you're interested in presenting in a future seminar series, contact Helen or myself. We've got great series of presenters lined up for the rest of the summer that have some spaces in seminars towards the end of the year, so bear that in mind as you carry on with your practice-based research projects in your own clinical areas. Okay, I'm going to stop talking now for a while. If you'd like to introduce yourself, feel free to use the chat box. If not, we've just got a couple of minutes now until we kick off with Lucy's presentation. Okay, thank you. Okay, so I've just noticed it's 12:05, so I'd like to introduce you once again to Lucy Rodgers, who's going to start off our seminar today, talking about co-occurring speech and language needs in children with DLD. So, fire away, Lucy.
Hello everyone, it's lovely to be here today. Today I'm going to be presenting on my research project, which I did as a part of my dissertation for my psychology masters with Birmingham City University. Helen, can I have the next slide, please? Thank you. So I used my masters as an opportunity to research an area that I've been particularly interested in my practice, and something I just really wanted to find out more about. And over my 12 years of being a therapist, working with children who have DLD or signs of DLD, I'd come to notice that a lot of the children coming into clinic tended to have speech sound difficulties as well as their language difficulties. Some children just had speech or language difficulties, but a lot of the time these overlapped. And I found it really interesting over the course of being in different teams and seeing kind of individual variation in actually how we support children who have co-occurring needs. So I then decided to look in this in more detail. And when I did a bit of digging, I actually found that, yes, there's quite a high proportion of children who have co-occurring speech and language needs. In fact, around 40% of children who are 4 years old who have speech sound disorder also have some signs of language difficulties as well. So that's quite a high number. And more so than that, these children are at an increased risk of longer term literacy needs and longer term speech sound difficulties in comparison to children who have isolated speech or language difficulties. So they're at a particular risk. However, what I also noticed is that a lot of our assessments and interventions tend to target either speech or language in isolation. So I'm sure many of you will be aware of the wonderful What Works database. And if you go on there and it lists a lot of evidence-based interventions, the majority of them will be for targeting speech or language. And we know that actually in the absence of kind of evidence-based interventions, clinicians are very creative and therefore naturally adapt their delivery of interventions that have already been established for either speech or language. So that's why I wanted to explore this topic further, looking at it from a very broad perspective initially at what are clinicians doing at the moment. So next slide, please. Thank you. Oh, I think it had to go the other way, Helen. That's the one, yeah. So my question was, how do SLTs, what are their experiences of working with this group of children? Because if we understand a bit more about the current challenges of working with them, we can maybe look at actually how can we improve our services for them and provide more targeted input. Okay, so next slide. So it was a qualitative research project. So I interviewed 5 speech and language therapists, all very experienced of working with this client group. And they had a wide range of experience as well. So some of them worked in clinic, some of them worked in mainstream, some of them worked in specialist DLD provisions, but more often than not, a lot of them overlapped as well. So I did 5 semi-structured interviews, and then after the interviews, I analysed my data and found themes within the data. So could I have the next slide, please? Thank you. So I analysed the data on a case-by-case basis initially and looked for key themes within each individual account. And then at the end of that, I then looked for key themes across all of the data. So patterns and connections between all the individual accounts to see if there were any kind of salient themes coming up or reoccurring. Okay, next slide, please. So I'm just going to talk through 4 of my key themes that I found. So one key finding was that 4 out of the 5 participants talked about how within the early years, they tended to target language before speech. So if you'll see here, Deborah talks about how they would tend to prioritise language before speech with these younger children. However, interestingly, Jane talked about how they might actually work on speech first or work on speech alongside language first, but only because they'd had experience of doing this with their cleft children. And this raises a really interesting insight in that actually, if we do work on speech with much younger children with the cleft population, why may we not do this with children who have a DLD profile? And I also just wanted to draw people's attentions to a really interesting article that was in Bulletin a couple of years ago that discusses this in a little more detail, and the pyramid model. Okay, next slide, please. So second finding, many of the participants, I think it was actually all of them, talked about how there were barriers to assessment. So specific barriers. So for example, here, Deborah talks about how with the DEEP, it's really helpful for assessing speech sounds, but actually if children don't have the vocabulary, they can't access the assessment. So it can't really be used. And then on the other hand, Jane talked about how for children with speech sound difficulties, she felt that actually they've got more language there, but it's actually really hard to tell because their speech is so unclear. So it really highlights actually that within this specific population, there are specific challenges relating to assessment. But also what I found was that the participants could be very creative in terms of supporting these children and assessing these children. So you'll see in this example here, Charlie talked about how they would use the STAS not just to assess the child's grammar, but also to look at the speech sounds at sentence level. So it also goes to show actually how therapists can be quite creative with what we've got, and use the assessments we have to assess a number of different areas, even if it's not standardized for that particular area. But yes, it kind of also kind of indicates that perhaps we need to look at this a little bit further and assessments for this group. Can we get something more specific in place? So next slide. Yeah, so another key finding was that there was a real big variation in how children prioritise target areas for this group. So Anne, for example, talked about how they would either work on speech or language, tended not to combine the two areas. Whereas Deborah talked in quite a lot of detail actually about how they would build in speech sound activities into narrative activities like colourful semantics, so work on them both together. And this again is quite an interesting finding in that no delivery of intervention is exactly the same. It's not completely prescribed because there are so many different factors we take into account when delivering interventions. But actually this is quite a big difference in terms of what to target first. And that potentially could have an impact on the child's outcomes with their speech and language. So again, it might be quite useful to look at this in more detail in future research. Okay, and next slide. A very kind of overriding theme really within my results was that a lot of the knowledge that the participants had and talked about, it was very tacit, it was very implicit, and therefore really, really difficult to talk about. So Deborah states that you do things quite habitually. And then Charlie also talked about how it just becomes a little bit innate within our clinical practice. And this again also has implications for future research, because it's really important for us to find out what clinicians are doing in current practice, because if we want to get an evidence base behind that, we need to make it explicit what's currently happening. And this is starting to happen, and some of you might know of a paper called It Depends, which came out a couple of years ago now, I think. And they use something called knowledge elicitation methods within their research study. So this is quite a useful thing going forward in terms of kind of extracting very specific information about what therapists are doing in their current practice. Yeah. So now I'd just like to pause and think about generalisation. Obviously, there was only 5 participants within this study, and they worked in very different areas. And there's lots of complex variables involved here. So we're looking at speech and language very much from an impairment perspective, but actually we adapt our interventions according to lots of different things like personal, child and family circumstances. However, what we can do is use the findings for initial insight. And And as I've mentioned before, actually, where can the evidence base go from here? And what do clinicians need to actually provide evidence-based care for this specific group who are at risk? Next slide. So what can we do now? So in the absence of evidence, there is a little bit out there, but there isn't much. What we can do is we can learn from each other. And what I really took away from what my participants discussed was actually, we are doing a lot already to adapt our interventions and our assessments for these children. But actually, we don't really talk about it. And as we found, it does become really implicit. So that makes it really hard to talk about. So one thing you can do, if you can, is to maybe arrange, say, 10 minutes of your team meeting or in group supervision or one-to-one supervision, bring along a clinical case to discuss whether the child has speech and language needs, and share that with another person, because you might be surprised actually with the skills you pick up and then want to try out for yourself. So next slide. So implications for future research. I included a picture of a very dynamic cake here, because this area is very, very broad and very complex. There's loads of different layers to it. There's lots to think about. And going forward, I can't possibly look at every single thing to do with children with co-occurring speech and language with a DLD profile. But what we can do is kind of share pieces of the cake and go forward together at looking at different areas. So potentially kind of different types of speech sound disorder, the impact of that. So yeah, we can definitely share it out together. And Deborah, as she says, quite often in research we get these very clear-cut groups, which is why it's important really to focus on these speech and language. And it goes back to what I originally said, with a lot of our research being about speech or language. Next slide. So going forward, I did an online parent survey just to find out what their views are and what their experiences are, because I'm an early years therapist. And they talked about how they received support for their child's language, but not for their speech when their child was younger, and weren't completely sure why, or kind of what the reasoning was behind that. And this is in line with my study findings. And this is something I'd very much like to take forward, looking at actually how can we target both speech and language within an evidence-based intervention within the early years. Next slide. So what's next? I'm currently developing an online forum which will give SLTs the opportunity to share clinical experiences. And I'm also really keen to engage parents and find out what's important for them, and can we build an intervention together that targets both speech and language that will work for them as well as for the therapist delivering it. Okay, next slide. So that's it. Please, if your question doesn't get answered today, please feel free to contact me on these details. I want to say thank you to my 5 participants as well for giving their time to this project. And also there are some references at the end of this slide that might be of interest to people. Okay. So any questions?
Thank you so much for that, Lucy. That was a really interesting presentation. Yeah, lots of people saying well done. It was really thought-provoking as well. I think no questions have come through yet, but I did have some of my own reflections, because I'm also interested in the kind of the co-occurring nature of difficulties that lots of our client groups experience. And, you know, have you thought about sort of how you might try, you know, any sort of research methods that have occurred to you where you might try to sort of draw out some of that?
Oh, that's a very good question.
Yes,
so the actual methodology for the next step, I'm kind of in the process of putting together. So I'm currently doing an ICAP internship where I'm looking at kind of how we might tease out the active ingredients of an intervention. And it's tricky, particularly speech and language, because they overlap so much. And what I'm particularly interested in is that in early years, we tend to do a lot of parent-child interaction focused work, which the evidence is for language, but actually in clinical practice, I've noticed that it can improve speech as well, because it's like an underlying kind of support for the parents. So what I really need to do is kind of look at parent-child interaction, different components of that, and actually what components of that might support speech as well as language. But it's a really thought-provoking thing, and something I'm still kind of developing at the moment.
Great, thank you. Actually, lots of questions coming through now, and I'm glad I got in there first. That did address one question, which was talking about whether there was an evidence base for whether that language therapy did impact on speech sound development as well. And I think you've addressed that quite nicely, and that maybe there isn't the evidence at the moment, but that's something you're interested in looking at. Somebody else asked, could you tell us a bit more about the forum and what your aims are for that forum?
Okay, so my aims for the forum is to have a sharing space for what I'm hoping to do is provide workshops to various trusts and kind of collate together my own information from these workshops and put onto the forum summaries of kind of current clinical practice of how clinicians are currently adapting interventions and kind of ideas for adapting assessments, and having that on the forum as a go-to place, a central place where people can go to. And I think when it comes to engaging with parents, they would have a separate forum, because I'm quite keen for them to have their own space, so that they can talk about their experiences of engaging with speech and language therapy services. And we can kind of draw out some key things that would be really important to address within the research going forward. I'm
going to have to stop you there, Lucy. Yeah, thank you so much for that. That's fabulous. There's lots more questions, which I'm sorry we didn't get time for, but we will save the chat and get those sent off to Lucy, because I think there's lots of food for thought there as well, lots of comments and feedback. So thank you so much again. Sorry to have to cut you off. I'm really keen that we move on to Anna's presentation next and trying to stay within time. So Anna Westaway is going to share with us your parents' expectations of how healthcare professionals communicate with a child with autism. So fire away, Anna. Thank you very much.
Thank you very much, Catherine, and thank you to Lucy for her presentation as well. I'm Anna Westaway. I work as a specialist speech and language therapist for Sheffield Children's NHS Trust, and hello to the Sheffield Children's team that are there today. I work in the complex and additional needs team with children who have the diagnosis of autism or have social communication needs in mainstream schools. And I'm going to talk about my project, Parents' Experiences of How Healthcare Professionals Communicate with Autistic Children, which I completed as part of an MA in Autism Spectrum that I did at Sheffield Hallam University, finishing in 2016. Just before I get started, I wanted to share this slide from a really recent webinar I attended, the Impact Symposium. And this was a slide from John Spears. Sorry, John, for having captured you in mid-speech there. Just showing that the process really of identifying a research problem all the way down to thinking about how research helps us identify good practice and how we can actually have an impact on the original problem. So my study is very much cited, I think, at the top of that ladder, looking at whether there's a problem and what might be causing that problem. So my first questions really arose about whether there was any sort of problem in how healthcare practitioners communicate with autistic children. From the comments that I picked up from parents through my clinical experience, and this is over a number of years, starting to hear parents comment things like, quotes like you can see on the screen here, describing what a stressful experience it is for some families taking their child to different kinds of healthcare appointments, how upsetting it is for the parent and for the child. Experiences like, it took 4 adults to hold my child down to take his blood, are really upsetting to read, and it made me start to wonder what part communication is playing in this experience, and whether there's anything that we can do to make that experience just a little bit less awful for children and families. So as part of my my study, you can see sort of the route that I took from my clinical role, which is ongoing, and via a little sidetrack onto my my autism spectrum study and a dissertation project. So through the dissertation project, I was able to think about this question a little bit further, about what healthcare is like for autistic children. And we can see that children who are on the autistic spectrum experience an increased range of healthcare difficulties, which includes epilepsy, gastrointestinal issues, sleep difficulties, mental health difficulties. And as a result of that, logically, they have to attend healthcare appointments more frequently. And then as a consequence of that, and this is a real focus of some of the US studies, their healthcare is more expensive. So whilst that wasn't a driver for me in looking at my study, I think we can appreciate that that's certainly a driver for healthcare providers. In thinking about why this experience of autistic children in healthcare is important, if there's anything that we can do that A, improves the experience, and also for the providers can help improve the cost. We know as well from the research studies that parents, autistic adults, and healthcare providers all say that the experience isn't very satisfactory for anyone. Autistic adults describe that they don't feel that the communication particularly is right. And so I started to think, well, that's got to apply for the children as well that we're working with. There is a few policies and legal frameworks that influenced the project as well. So above the line are the ones that I was aware of as I was undertaking the project, and then below the line were the ones that are emerging just as I was completing the project. And I'm going to talk in a bit more detail about the implications in terms of the accessible information standard later. So my study design involved creating an open style qualitative questionnaire for parents, and I was able to have some parent involvement in devising the questions for that. So following the literature review, I developed the questionnaire, and I recruited families via two different routes, via a family support charity for autistic children, and also via a number of parent online forums. So parents could either complete the questionnaire as an online survey as a paper hard copy. My three main questions were to ask, what are the experiences, both positive and negative, that parents report of how healthcare professionals communicate with children with autism? I wanted to know how the healthcare practitioner's style affected how the child responded in the appointment, if that had an impact on their understanding, their processing, their ability to express their needs, and also how parents felt about the whole thing. If healthcare practitioners communicate in different ways, how does that affect how the parent perceives the appointment and the professional? Once I'd gathered my data, I explored the findings using Bourne and Clark's method of thematic analysis to summarise the results into the 6 themes I'll go on to explain, and then I made some recommendations based on those findings. My screen's not moving on, Helen. Oh, here we go. There we go, it is moving on now. I had 16 respondents altogether, and I didn't ask for a great deal of data about the children as part of the project. I asked for parents to report that their child had a confirmed medical diagnosis of autism, and I asked for a simple description of the children's communication skills. And this is what the parents told me about. So whereas in my job I'm working mostly with minimally verbal autistic children, you can see here that the majority of respondents reported that their child had conversational level language. There was a huge range of findings, and many of those are positive as well as negative, which was encouraging. I think I'd gone into this really expecting to hear more about the negative experiences that families have had, but nearly every respondent was able to give me some examples of good and bad communication. And I organised those themes into those that describe the impact of effective communication and those that describe the impact of ineffective communication. And whilst this might sound very obvious, the ways that parents described what constitutes good communication was the exact opposite of what they described poor communication to be. And I know that sounds obvious, but to me that just really added weight to the findings, that they talk about both things as being the exact opposite, so that you can see exactly that they mirror each other, but not just through common sense, through the parents' actual evidence. The biggest impact for me from the whole project was hearing the parents' description of what communication was like in healthcare, and these are just a very, very small range of some of the responses that parents gave me, some good and some bad. I would love to have been able to delve into that in more detail with you today, but I want to go on to just talking about the broader themes and the implications for practice. But if anyone would like to know more about some of the comments, then please do contact me. So you can see on the left, I've got all the main themes that relate to the impact of effective or positive communication. And then on the right-hand side of this table, there's all the themes that relate to negative or ineffective communication. So starting with number 1, parents described that effective communication from healthcare practitioners is focused on the child. So that doesn't necessarily mean that it's always involving the child. For some parents, Focused and attentive to the child meant reading the child's signal and understanding when not to communicate with them. There was also a really strong theme about adapting the language to the right level for the child. Again, for some children, that was using more adult conversational style language. For others, that was really reducing the language style down to single and simple words. But all participants were really, really strong that it needs to be well paced and allow time. Conversely, ineffective communication doesn't involve or doesn't engage the child well. It doesn't adapt to the style of the assessments, and there was a lot of comments about the lack of reasonable adjustments that were made in healthcare appointments for autistic children. And communication is ineffective when it's rushed and abrupt, and that's partly a factor of the time limits that healthcare professionals have, but that's certainly something that parents want to see addressed. When healthcare practitioners get communication right, again, these will seem really obvious responses for us as speech and language therapists, but it's important to have it in data for healthcare practitioners to know that what they do affects the child. When it goes right, children are relaxed and calm, they can respond and they can communicate well, and they can actually comply and cooperate with the investigations, which is the whole point of being there in the first place. When healthcare practitioners get it wrong, children are anxious, they may be avoidant, and they may display behaviours that can be construed as challenging. Finally, when healthcare communication goes well, parents feel relaxed and more positive, and they're much more confident in our abilities and in our skills and how useful the appointment is. And they feel that they've been treated with respect as well as their child. The opposite, when it's ineffective, parents are angry and stressed. They lack confidence about the healthcare process, and they feel quite insulted. They feel blamed for their children's behaviour, when in fact it may have been a response to the communication style or the approach of the appointment. I gave parents a few ideas for what might be useful suggestions for improving healthcare appointments in terms of communication, and I also asked parents to add their own ideas. So these are some of the recommendations that parents made about how we could improve the communication process for appointments for children who have a diagnosis of autism. And I've summarised these into some main recommendations, mostly about our training needs. So we need to train healthcare practitioners in what effective communication looks like for autistic children, as well as children and adults with other communication needs. We need them to understand that it's child-focused, that it's adapted to the child's level, and then it needs to be calm and patient. We also need to make healthcare practitioners aware of what parents' priorities are for how we improve communication for autistic children, that parents want to be involved in giving advice on what's the right way to approach and communicate with their child. They want healthcare practitioners to have better understanding of how they can be flexible in their communication style and use alternative methods of communication. They really, really want timing to be improved to allow communication to go smoothly, both before the appointment and actually during the appointment itself. And they want healthcare practitioners to have better skills at engaging the child to create a sense of ease. So to do all that, we obviously need to find better ways of sharing information, be that better ways of communicating directly with parents to inform practitioners what the child needs before the appointment. And that could involve systems like healthcare profiles or healthcare passports. Sorry, I've got a slight screen delay here. Helen, if you're able to move my slides on, it seems to have got stuck. There we go. So the applications of what we can do better. This is my call out to all therapists who are working in NHS provisions. If you're not aware, or if you're not involved in your trust implementation of the NHS Accessible Information Standard, try and get involved if you can. If you read the standard, it's our stuff. All about adapting communication styles. It's about using AAC methods. It's about putting the right support systems in place. This is what we do on a day-to-day basis, and I think that our trusts really need advice from our skills and knowledge about how they can do that effectively. We can raise awareness of the 5 good communication standards for healthcare, and for me those apply just as much to children as they do to adults, and also promote communication access training across the UK in our settings as an easy, simple way in for healthcare practitioners to have some direct training about communication. Apologies. There we go. Just a quick overview of the Accessible Information Standard for those of you who aren't aware of it. Healthcare practitioners and adult social care providers are expected to ask if there are any additional needs, record them, make sure people are aware of them, share those needs, and make sure that the needs are supported and that steps are taken to implement any support that's required. And specifically, those 2 areas of support relate to the provision of accessible resources that might be paper-based or written, as well as those that facilitate the actual communication interaction, the face-to-face interaction. I know I'm nearly at the end of my time, so this is a little bit of a slide just looking at how my role has developed and how my work has developed as a result of carrying out this work. And I will stop there so that we can go on to any questions. Thank you.
Great, thank you so much, Anna. That was really fascinating.
I have references, and also these are my contact details at the end.
Yeah, thank you. That was really great. And one of the key messages for me was actually a lot of your findings do relate to not just all people who've got communication difficulties, but actually all patients across health services. I think if we took all of those standards forward, wouldn't we all become more relaxed? And
one question I did ask parents was, if they had children who weren't autistic, did they have a different experience of taking those children to healthcare appointments? And they said it was a bit different. So there is something a bit unique about the experience of children with communication needs compared to other children that I didn't have a chance to fully explore, but there's something about that too.
That's great, which leads us really nicely onto one of the questions that one of our attendees asked, which is about your thoughts for future research, and potentially is there a role there for some sort of ethnography or observing healthcare appointments to see if you can understand some of that sort of...
That's a fantastic idea. So one area that I think is really, really missing in the research is the voice of the child in terms of talking about their experiences. There's some evidence and reports of adults' experiences, autistic adults' experiences, but very little in terms of autistic children's experiences. We've got parents' experiences, we've got the healthcare practitioners' experiences, but I think it's some way that we could capture what the children themselves say and feel about their experiences in healthcare would be so valuable. Ethnography sounds like a really interesting way to do that.
Great, thank you. So lots of really positive comments thanking you for your presentation.
Thank you.
And somebody else again commenting that they work in education, and this is another area for translation. So I think there's so many lessons which permeate all areas that we work in, aren't there?
My role is mainly working in schools, and the approaches that I've learned from working in schools completely mirror the approach that I'd like to see more involved in healthcare. I think they apply to any sector.
Which brings us nicely onto one of our other questions, which was whether you have any recommendations for how research could be used by speech therapists who maybe work in local authorities, so not with healthcare providers, but potentially social workers, people like that.
Yeah, that's interesting. The accessible information standard does apply to adult social care settings as well, but not paediatric social care settings. There has been quite a lot more research coming out since my dissertation that I've not been able to keep so up to date with. But it depends what context that person is working from. I think if they're working in an adult setting, there's probably a much wider range of research that looks at adult experiences and what approaches are effective for adults. But I would say I think there's another gap in the research. We know a lot about people feeling dissatisfied with their experiences, but I don't think we have as much research about the things that actually do help, that do make an impact towards the end of that very first slide. So I'd be interested to look at research reporting successful approaches to adapting the environment in social care settings and in healthcare settings to make that experience more satisfactory.
Yeah, that's great. Thank you so much. I think, like I said, there's so many lessons there for people, for all speech and language therapists. And I think, promoting what we can offer in order to create more facilitative environments for everyone really is so important. So thank you very much for sharing that. Okay, once again, we'll share the comments, save the comments and questions from the chat to be able to share those with you. But we are now going to move on to Jenn Warwick, who's going to share with us a presentation about developing a sociocognitive communication battery.
Hi there, let me just check. I'm trying to check, see if the screen moves for me. It doesn't seem to, but that's fine. If someone doesn't mind moving it onto the first slide, that would be great. So yeah, I'm Jennifer Warwick. I'm a speech and language therapist, and I'm talking about the development of the early sociocognitive battery. If we can move slide, that would be great. Okay, so what I'm going to talk about really is what is the ESB. It might be something that some people have heard about, it might not be, so in which case I want to provide a bit of an overview, talk a little bit about the development of a clinical tool and implications for practice, but also just, I think it's helpful to share, I think, my experience of being involved in this process. I think in terms of helping other SLTs sort of who might have an idea about getting into research or, trying something or linking up with a university, just having those opportunities, I think, to develop skills really. So and I have got references at the end because it's quite a lot to cover really, but really, so the ESB, it's a preschool assessment, and I first heard of it. It's been developed from research done by Penny Roy and Shula Chiat at City University. I first heard about it when I was doing my MSc at City, and at the time I was working in a child development team with preschool complex needs, and I thought, this is amazing, this is what I need in my practice. So even though it wasn't part of my MSc, I became involved with them. This was probably about 7 years ago, and just starting to try and use it in a way that we were getting some evidence about how people were using this in practice. So thinking about what it is, so really it's theoretically driven. As I said, it was based on research from Penny and Shula, which was originally called the Very Early Processing Skills. It was a research project, a longitudinal study that started in 2003. And I think it's a great example in terms of that research being turned into clinical practice, and that's something that I think as speech therapists is really difficult, because I often see things that I think, wow, that looks great in practice, or I read about them, but actually trying to implement them into what you're doing is really difficult. And actually there was someone at RCSLT conference this year, and I think it was the first lady that presented, and she said sometimes, you know, these things take about 20 years to get into practice, which is really interesting if you think about it like that. So why I thought it's useful to share this was really the ESB was kind of developed as part of a collaborative project between clinicians and researchers. And we wrote an article for Bulletin a few years ago, which goes into that in more detail. If we can move on, that'd be great. So what we know, if you work in preschool, there is a big link between language development and interpersonal engagement. I think no one will be surprised to hear any of those things. These skills, which come under that umbrella of sociocognitive skills, are important for language development, but we know that they're things that children with ASD find difficult. So we're talking about things like joint attention, we're talking about symbolic comprehension, we're talking about response to facial expressions. If we can move on. So I think when we assess these things, and I think my background working in child development is that when I first started working for the team, there were incredibly experienced speech therapists who would just look at children. They'd be able to kind of pull their assessments and their observations together. And I think these skills are not things, you know, speech therapists always include them in what they're doing in their initial observations. And whilst these are really relevant, so going back to when I first started working, these very experienced therapists, that was based on their clinical judgment, and absolutely right. But they're still quite subjective. And I think when you're working in a multidisciplinary team with other professions, so pediatricians or psychologists, who I think tend to use a lot more tools, tend to use a lot more standardized tools than we do as speech therapists. So we absolutely know, you know, we might be assessing joint attention in this way or another way, but it's kind of still quite subjective. So I think if we move on, what struck me was that when I heard about the ESB, I thought, this is great because it gives me a slightly more systematic way to assess these skills, which actually it really helps make sense for parents. So, you know, not just, well, the speech therapist said, but the speech therapist has used this and I've had this opportunity to observe these skills. So thinking about using the ESB, it's an assessment that takes about 15 minutes to complete, and there's 3 subtests that consider social responsiveness, joint attention, and symbolic comprehension. So if we move on, this should be a video. I hope it works. So if we try and click it, see if it does. If it doesn't, it should work. You might be able to hear it. I can't hear it. I don't know if anyone can hear it. No, probably because it's not enabled for sound. So basically, Steph, the therapist in the video, you can see the little girl's looking, making facial expressions. She is taking items out of a bag, and that one, she says, my brother bought some toys to play with. She takes out a nappy, she looks at it, that's not a toy. And you're looking, do they look at your face for 2 seconds? Do they look at you for 1 second? Or do they look at you not at all? So you're looking to see how the child's responding to your expression. And that's then scored as part of the assessment. If we move on to the next one, it's worth playing it because you can see it even though if you can't hear it. So this is using, sorry, I'm very pregnant in this video. It's about 5 years ago. So we have an egg, you're putting the egg out. So you're giving the child an opportunity to look at the content of the egg and back to you. And then I do this very strange thing when I'm looking to see if they can follow my gaze. And then if they don't, looking to see if they follow my point. So we're looking really specifically at how we're measuring gaze alternation and following points. And the child is given 6 chances to do it. So each of the subtests has 6 chances, which are then scored as part of the assessment. So if we move on to the next one, look at symbolic comprehension. So we look at how does a child understand gestures? Do they understand that this means scissors? Do they understand this might mean drink? So moving on to the next one. Then we're also looking at their comprehension of miniatures, and then on to the next one. And then a substitute object. So, you know, if I'm pretending to eat from a shell, does the child understand that that is a plate? So being able to, and there's obviously some cognitive load in that, but I think it's looking at that ability to symbolize. And I think a lot of the time when we're looking at assessing things like pretend play, I mean, I use the symbolic, is it called symbolic play test, the Lowe and Costello one? I used that for years, and then I was actually thinking about it, and I was like, don't really need to do any, there's no symbolic thought in it really, because a lot of what you're doing is acting out scenarios that you've seen lots and lots of times. So you're giving very specific opportunities for a child to develop, to demonstrate those skills or not. So if we move on to the next one. So basically, when we're using the ESB, the assessment is scored and it provides a structured and systematic tool to look at these observations. So we're looking at observations that SLTs would probably always be using. So none of the skills that we're assessing are things that you probably wouldn't be looking at in your initial assessment with a preschool child. The thing that maybe differentiates the ESB from some of the other checklists and things out there is that they're elicitation based. So we're giving the child the opportunity, we're presenting them with those 6 chances to respond. We're not just asking the parent, do they follow your point, or how do they look at you? Because I have numerous clinical experiences of where I'm saying, oh, does your child look where you're looking, or look where you're pointing? And the parents say, yeah, they do that all the time. And, you know, then you're trying to do it and the child's not, or you're, from your clinical observations, you're thinking perhaps this is something that this child is struggling with. If we move on to the next one. So from when I first became involved with the ESB, it has now been fully standardized. So on 400 children across the UK, I was lucky enough to be involved in that standardization kind of process, which for a clinician, it was just really useful for me to kind of understand more about that. What they found was that it's predictive of social communication difficulties. It's also a predictive measure of ongoing contact with SLT. So children who score low on the ESB are more likely to be receiving speech and language therapy input in their last year of primary school, and also those children who get a late clinical diagnosis of ASD. So children that score low on the ESB are likely to have those difficulties. Another key finding from the standardization is that the performance is unaffected by bilingualism and ethnicity, and less affected by SES than language measures. So we use the BPVS alongside the ESB, and it's much less affected by SES. And I think those things are really important to think. I mean, I work in London, and a lot of the children, a lot of the caseloads are multicultural, and it's very difficult, I think, to be assessing children where assessments aren't necessarily standardized on a certain population. So I think that's a key finding, and something that makes it really applicable to using in early years as well. So I guess the takeaway is that it's psychometrically robust and it's reliable and valid, which I think as SLTs, it's just really important for us to be aware of that, because often I feel like when I'm questioned by colleagues in their MDT, well, what are the scores, or, you know, how do you know, what's that based on? It's just useful, I think, to have something that is more than just our clinical judgment as a kind of step for that. So if we move on to the next one. So I think if we're thinking about implications for practice, that key thing, like I was saying, about it being very relevant for children from diverse language and cultural backgrounds makes it something that is a really useful tool to be using with preschool children. I've just seen someone's typed that about what age is it for. So this is something that is, it's specifically, it said at the beginning, for preschool children, standardized for children age 2 to 5. And I think that clear framework for discussion with parents is what's really important. So generally, we would recommend parents, like, you know, they're observing the assessment that you're doing, and then it's actually providing you lots of opportunities to have that discussion with the parent, because they've seen how their child performs, and then it's giving you an opportunity to talk about the skills that you're observing and then what you might target in therapy. I think for me, my background in early years, kind of early years with complex needs, is a lot of parents come to speech therapists just thinking you're going to be working on talking, and actually when you're saying, look, we need to target all of these very early skills, we're going to be working on joint attention, we're going to be working on all of these sorts of things, I think that can be quite challenging. So I think if parents have had that opportunity to observe, it can be really important. So again, another implication is that potential to separate out late talkers to more persistent difficulties. I know I've got to finish in a minute. So so we know that it's a useful tool as well for identifying relevant interventions in terms of what we might do as next steps. And I think, again, from therapists that have been trained in using the ESB, they found it a very relevant and kind of useful measure. I'm just looking, there's lots of questions coming up, which I will get to. I'll just see, I think I've maybe got one more slide. That's the references. So yes, and I think part of the reason why I wanted to sort of share this today is it's partly my experience with this. It's something that I think I've been really committed. I feel really lucky that I've been named as an author on the ESB, but it's something that I have felt is so clinically relevant for a really long time, and being involved with something that's gone from a research tool to kind of making the kits ourselves and trialing them and then getting it standardized to now being something that's published and available has been really helpful for me. And I definitely don't consider myself as a researcher in any way, but I'm doing a part-time PhD at City, but I think it's definitely helped me develop those skills and the confidence to sort of be involved in different aspects of kind of SLT work. I can see people are asking in terms of predictive nature. I think it's definitely worth looking at the papers. So it is predictive in terms of later diagnosis difficulty. Someone's asked about early scores on the ESB are predictive. It is predictive in terms of, the questions keep moving, so I can't see them.
Okay, Jenn, if you just want to sort of wrap up your presentation and then I'll come to the questions, because
fine.
I've got a list of
Sorry,
them.
I kept seeing it kind of coming up. So basically kind of that's it in a nutshell. It's very difficult to, I guess, present in about 2 minutes because we run a full day, a clinical training day at City. We've actually just set up an ESB website for people to find out more, which is really, I really like what Lucy was saying about wanting to have kind of like a forum for therapists, and that's kind of what this is about. So wanting to make it clinically available from the research that's been done, but also then having a forum for therapists to be using it. We do have some teams, so there's a team in Manchester who are using it routinely as part of their sort of ASD pathway, and some other teams who are using it as part of their routine screening of children. So yeah, it's great to kind of be able to share good practice and hear how people are using it as well. But I'll finish because there's quite a lot of questions. So yeah, I can get to them.
That's great. Thank you so much. That was a brilliant presentation, and it's really fabulous to see how academics and researchers working alongside clinicians can generate these really useful tools and materials which are relevant to us in our clinical practice. I feel quite passionately about that. And I think you talked about not being necessarily a researcher, but in a way, I think as speech and language therapy clinicians, we're all researchers because we all ask questions and then we're interested in finding the answers to those. And research just gives us a separate sort of toolkit in a way in order to
completely agree. Yeah, absolutely.
So thank you, it's fabulous. So I did collect a couple of the questions. There was one about how the couple have come up about how we could use the tool remotely. So I think that's very prescient. Have you been able to use this tool?
Do you know, I think we've had quite a lot of queries about that, and I asked Penny and Julia about it, and I think it's tricky because it's only so recently been standardized and made clinically available. I think there is actually no move at the moment to be trying to do it remotely. I know some people are going back to face-to-face working. It's definitely something that you can do in quite a distanced way. I would say though that the manual is incredibly helpful. I mean, I read it and thought, wow, I've learned loads of things. I think she did most of the manual in terms of just understanding about those very early skills in young children. So I think even if you can't use the assessment, if you're not working face to face, it's still maybe a good time to be doing the training. In terms of next steps, I ran out of time to say them. we are developing an online train. So we run training via City. You don't have to be trained. So the assessment can be used for speech therapists. It can be used by psychologists. It can be used by pediatricians. If you're trained in something like ADOS, you probably could pick it up and run with it. You don't have to do the training day, but people really are interested in doing the training. And they seem to, we have great feedback about it. It's a really informative day run by Penny and myself at City. So at the moment, that training is now online. So we're doing it via Zoom, but also the publishers, Hographer are the publishers, and they've really encouraged us to do an e-learning as well, which is also being developed. So that will be for sort of use in different countries as well. So yeah, but I can share all that in terms of the training.
That's great. So you've answered a couple of questions there already. Other people were asking sort of future plans in terms of research. So there were some questions about whether it is predictable for particularly girls in terms of an autistic spectrum diagnosis, I guess, going forward. Are there any plans for a longitudinal study to look at the results that children get from this particular test and maybe longer term outcomes?
Well, I think that is what probably Penny and Shula are really keen to look at, to compare the details with something like ADOS. And I think that's why so much of this is about clinicians getting involved and going back and looking, what projects can we do in our place of work. And I think at the moment there's a trust that we have been working with, and that we've got a meeting in a few weeks with the paediatrician and the lead SLT in terms of looking at gathering that data. And I think the thing that's so nice about it is that it's coming from clinicians who are using it and thinking this will be really helpful in terms of gathering that. I know there's quite a lot at City there's a few MSc projects using it at the moment. But absolutely, I think in terms of gathering that information. In terms of girls, I think if you look, I think it's the paper, it's maybe one of the most recent ones where with the information about the standardization, or I think perhaps it's in the manual, there's a very slight gender effect at certain ages, but it's not generally impacted by gender in terms of the results.
Thank you. You addressed lots of questions in there. Someone else was asking how it would be complement or be used instead of ADOS, which is an acronym.
I think that's interesting because actually we do have a team. There is a team who are using it. It's not meant, it's not something that was published to be used instead of. I think in a way, it's my feeling with it is that it's something that can signpost, does this child need an ADOS or not? I think when I worked in ASD diagnosis as part of the NHS, I felt like we still saw a lot of children who didn't need that referral. And if we're thinking about clinical resources and time and all those sorts of things, if you can have a really good screen to make sure that the children are being referred for that, they really need it. I definitely see the ESP having a place there. But like I said, there is a team at the moment who are using it as part of their diagnostic pathway. Someone else I just saw has asked about what the scoring is like. I think the best thing to do is to go onto the Hographer website and look up ESP. I should have it here. It comes in a beautiful, honestly, it used to be in this terrible bag with all these toys and things. Now it comes in a really nice suitcase with the scoring sheets and the manual and everything. It's very easy to score. It's quick, so you can feed back there and then to the parents as well.
That's fantastic. You covered a couple of questions in that answer as well, because someone was asking whether it came with all the resources or not.
Yes.
So, fantastic. All right, we're coming towards the end of our seminar session. So thank you very much, Jen. There's some more questions coming through, but I'm not sure we'll have time for them right now. I just want to take this opportunity to thank all our speakers today. We don't necessarily plan to coordinate themes in terms of the seminars, but I think there were some sort of themes running through today's presentations which were unexpected and delightful and have really helped consolidate my thinking anyway. This is an area which is completely new to me and I've just found it fascinating, so thank you very, very much. Our next seminar will be on the 12th of August, and again we've got some fabulous presenters lined up. So we've got Jan Valzeman, Eleanor, Lorraine and Steph Burgess all going to talk to us in that seminar. Please do sign up or circulate that link through the normal channels again. And just to highlight, if you want to take part in any of the seminars, then please do get in touch with Helen or myself. There's lots of other online opportunities coming through at the moment. So do keep a check on Twitter and see what, how some of our sort of partners supporting evidence-based practice and practice-based research are offering up opportunities for people to get involved in CPD and online learning. So it's just hit 1 o'clock. We're going to finish up there. Thank you very much for joining us. It's been great to see it. It's another really popular session, and we're really pleased that you're all getting something from it.